it's kind of a crisis which existed before COVID-19 that dramatically worse during it, and has, if we observe the trend, hasn't fully recovered since. And the burnout of our healthcare workforce, which is kind of a key important issue because they are the first responder for any health concerns. So we'll quickly go into the topic. Just a couple of slides about my profile. I'm a digital transformation expert in healthcare with more than 20 years of experience, currently working in Cognizant. My co-author, Nandakumar Raju, he's also a technology experience expert with healthcare technology expert with 25 years of experience. He works in Optum UHG. Let's come over to extract. So as I mentioned earlier, the topic specifically focuses on burnout and utilization of AI resources on managing the burnout of our healthcare workforce. So this is a review paper. We didn't do original research. We identified credible sources. Utilizing that, we did our secondary research and then drew conclusions and applications of AI, how we can do that. So this review does two things. It compares the burnout rate across pre-pandemic, pandemic, and post-pandemic periods using the CDC, AMA, and the Veterans Healthcare, the VHA, the Veterans Health Administration data, and it maps how AI is being applied across 6 domains, which we have identified to ease the workload that drives the burnout. Some of the numbers to start off with the conversation: the physician burnout peaked roughly around 63%. We'll cover this in further detail as well. Around 2021, the highest rate which was ever recorded, which is a huge amount, more than 50% of the workforce. By 2025, it had fallen to around 42%, which saw 4 consecutive years of decline. But still, although it was a little bit progress, but still 42% is still well above the things which stood before the COVID-19 pandemic hit us. So from a broader workforce, we have the nurses, technicians, the support staff, the CDC data that ends at 2022 at around 46%. There's been no update which have been verified since, which we'll look into that trends as we go. So overall, the conclusion which we drew from this review was the economic weight is really significant. The physicians, they burn out around costs and estimated like $4.6 billion annually through turnover and reduced clinical hours. So let's go into the further details. We'll focus on the research methodology first. So this narrative, as I mentioned earlier, it's a review. It's not an original research. From the burnout trends, we drew 4 publicly available data sources: the CDC Quality of Work Life Survey covering all healthcare workers from 2018 to 2022. The AMA National Physician Survey running since 2011, the VHA 6-year longitudinal study data from 2018 to 2023, and a 2024 meta-analysis of public health workforce. One important caveat that these resources use different instruments, so their absolute percentages are not to be directly comparable across the rows. What reliable is you can say the direction of changes within each sources. For the AI section, we also drew peer-reviewed studies from 2020 through early 2026 and reporting the burnout outcomes and related measures like documentation, time, task, and load. So let's go on to the actual trend. This is the anchor slide of our whole review of the research, where we identify the burnout trends across the 4 sources, which we mentioned earlier. So as you show on the figure, there are 3 independent data sources. They tell the same story. The solid line, it's the Mayo AMA triennial line, which shows the physicians' burnout sitting at around 45.5% in 2011, which declined to around 38.2% in 2022, which was lowest in that whole decade. But during the pandemic, it exploded to close to 63% by the time it was 2021. That's roughly a 25% jump in single year, which is driven by surging volumes, exposure risks, equipment shortages, moral weight of rationing care as well. And we knew the entire situation which happened across the globe. Since then, the AMI annual series has shown 4 years of continuous consecutive decline to 53% and down to 42%, close to 42% in 2025, which is a good progress, but still, as I mentioned earlier, it's above the pre-pandemic levels. The AMI notes that the emergency medicine physicians, especially, they remain close to 50% today. That means the recovery is not uniform across the specialties. The other trend is the CDC dotted line, which covers all the healthcare workers, which is like 32% in 2018, 46% in 2022. We didn't have a data because there was no published data updated since 2022. So the three callouts on the right, if you see on the right side of the screen, they capture the key numbers, which is like three times the figure. Especially the CDC analysis found that the workers on the understaffed organization were nearly three times as likely to report burnout. Understaffing is not just a correlation, it is one of the strongest, you can say, predictor of the data. And the tools, any tools that genuinely frees up the clinician's time, specifically doing the data work, the writing work, etc., it does address this directly. And we will see in this categorization, which we did as part of our review study. So these are the 6 domains where we listed them in the table, which organizes the AI tools into 6 domains based on what work they take off the clinicians or the physicians' workplate. So one of the most important, if you see the column in the middle, it's the strength of evidence. So because what should drive investment decisions, these are the, you can say, the evidences which kind of give you very solid outcomes based on which the AI tools, which we have identified in the subsequent slides, will identify, which affect the outcome and the optimization of the workforce, and then thereby indirectly or directly reducing the burnout management. So documentation is the only domain which is related or rated as strong. They have done multiple control studies which have directly measured burnout reductions, decision support, scheduling, patient flow, which is developing. Therefore, the real adoption and optional evidence, but burnout specific studies are still very, you can say, limited. So patient engagements and training are still in early stages. So that kind of summarizes all the 6 domains which we identified. The main concern column matters too, because we identified what are the issues related to each one of these domains or the categories. So, for example, the note accuracy for scribes, the algorithmic biases, the descaling for decision support, fairness, labor relationship for scheduling, surveillance risk, patient monitoring tool. These are the 4 underlying technologies across these domains, which kind of are utilized through large language models, the speech recognition, retrieval augmentation generation, and agentic AI systems. So that's the categorization. Let's go to the actual tool. So what we did as part of our study was we identified some of the emerging trends, and then we categorized them across these 6 domains or categories. So this table here provides a snapshot of the market as of early 2026. Over the last 5-6 months, there might have been some changes as well. So this is like till mid-March or early March of 2026. By the time it's like year end, there might be huge changes as well in these tools and how they are being utilized. So we'll take a few examples here. In documentation, which has the strongest evidence, we had Abridge, Microsoft DAX Copilot, Suki, Ambience, Nabla, Heidi, etc., which are the major platforms. In February 2026, one of the things which we observed during our research was Epic announced its own native AI charting features. So this gives Epic's dominance, and we know like Epic occupies close to 70% of the entire EHR healthcare system market. So Epic's dominance in large healthcare system that has potential to reshape this market entirely. In decision support system, we have open evidence, which has like close to 40% of US physicians registered on that tool by mid of 2025. There are 2 macro shifts that are worth discussing here. First is the movement from passive to agentic AI. Tools that are like kind of, they suggest the orders and the queue of prior authorization. Prior authorizations, as we know, like for any approval of any medical procedure, there has to be an underwriting prior authorization paperwork. This has to be done. So these are not just like draft notes. Second, consolidation around Epic, which they force the third-party tools to provide clear advantage over the native capability as well. So those are some of the tools which we did study. A couple of case studies which we took as part of our review was the Aetna Health and the Yale. So let's quickly touch base upon that. The first one is the Aetna Health Physician Sentiment Survey. It covered about 1,000 physicians per year. It was a vendor funded, conducted by Harris Poll. The 2025 survey roughly found like Around 10 percentage point dropped in self-reported burnout from previous year or the prior year at the 2025 level, with 68% of physicians reporting increased use of AI for documentation, which is, as I initially mentioned, documentation, writing process. The desk work is one of the major concerns at the end of the day for all these physicians. So that really helped the use of AI for scribbling and utilizing the for reducing the documentation effort. So this is a useful scale indicator, but it's kind of but it is correlational, you can say that. Year on year samples are different for physicians for different specialties, and we cannot really identify specific pinpointed changes. There might be effort in optimization as well, where the physicians they change the way they work, distributed offshore the work as well, which is I'm sorry, it means outsource the work, not really offshore. Outsource the works, which kind of contributes to along with the AI implementation or the changes which we did. For the other case study, one of the stronger evidence, it comes from Yale's New Haven multicenter study. It was published by JAMA Network Open in 2025 by Dr. Christine Olson and Dr. Lee Shom. They worked in 5 other healthcare systems: the Christus Health, Memorial Care, the Christ Hospital, Sutter Health, evaluating the average ambient scribe across 263 ambulatory clinicians. Before the scribe, 52% reported regular burnout, around 30 days, close to 39%, which is a 13-point reduction, pardon me. The overall load, the cognitive load afterward are documentations and the attention to patients during the visits, they all showed improvement. The result, which was across academic and community settings and across all the specialities of the physicians, it showed that kind of a 13-point reduction in the burnout management. So although for these 2 case studies, the limits are there, there were limitations in the survey. They had like the self-selected clinicians. It was a short follow-up about just about a year. And one was a vendor initiated or co-authored, and the other one was like a statistical work which was done independently by Yale. But together, if you see the overall trend as a sample case studies, these 2 case studies, they make kind of a stronger case than if you take it each one of them alone. So that's the reason we did kind of a varied survey of case studies and came up with this outcome. So the Aetna Health, they show trend at scale, while the Yale, they showed a specific measured reduction under a careful design. Let's go to the implementation part. So while we discuss about the tools, we discuss about the categorization of the domains, we come to how do we implement AI utilization, because that's also where one of the challenges where these large hospital networks and physicians, clinicians, they face, which is implementation. So here we have a 3-tier sequence. It's again an indicative based on our research and review. Every setup, they have a different or customized implementation model, as we see with any other AI or software-based applications. So it's a 3-tier sequence. It's kind of the base is very simple. You match your investment to the strength of the evidence. So here we identify tier 1 is documentation. We typically start here documentation, and as we know, EHR in healthcare, it's one of the largest thing and one of the largest concerns as well in terms of regulatory and PI as well. So we start here. The evidence here is strong, as we saw in that 6 domains. Documentation is one of the strongest evidence which help reduce the burnout through AI interventions. So here, with the evidence strong for documentation, we have the AI EHR integration, which is currently in a mature state. Then the implementation pattern is understood. And before we go live, the 3 things which are absolutely imperative and non-negotiable, they are like the best measure the baseline burnout with a validated instrument before we deploy anything. Because without a before and after, you can say a comparative analysis, you cannot really credibly claim an impact. So you have to identify, okay, this is where we are, and this is where we are after the implementation. Most of the times, because these are the hospital networks, they are not technology incentives, they kind of negotiate a vendor contract. So if they outsource this, then they have to explicitly mention that you are not allowed to use the PHA or PAI for creating your model or training your model specifically when you are using that AI tool or implementation. We have the concept of federated learning and federated training, where we kind of mask the data before we use it into the AI models as well. So we Then we establish a physician's information, you can say information owning, regular accuracy, add audits for these AI drafted notes, etc. The second tier, it's about the decision support, scheduling, and patient flow, which was part of our six domain framework as well. This should be, rather than implementing directly, what we find during the review was it should be piloted one service line at a time, with a measured kind of a, or you can say a structured build right from the start. I know we have just 5 minutes. I'll quickly go through it. So we have like the scheduling AI for advising human manager, not replace them. Then all the regular terms which we say like AI is there to augment and help support rather than kind of replace the thing. Then we do the algorithmic fairness on the patient population, not just the vendor validated data. The third tier is the patient engagement and the well-being monitoring, which requires governance, which is imperative across any implementation of any tools or any system, or system architecture changes as well. So wellness monitoring data must be firewalled. As I said, like this includes PAI, PHI as well. With credentialing and performance review, patient-facing data should have the clear escalation path, etc. So these across these three tiers, we see like what we have to observe is we have to plan the full cost. Typically, we take 5 years of full total ownership, and then the ROI against it 2 to 3 times the, you can say, take into consideration the license fees, the audit fees, retraining, change management, etc. needs to be included. Quickly go into last couple of slides. The governance, ethics, and key challenges. So these three issues determine what happens next. The governance of the vendor contracts, they should be about the utilization of data and model training without consent should not be there. So all these clear guidelines needs to be there. Well-being monitoring tools, etc., needs to be in place as well for performance management, and the policies needs to be defined in practice. Second is the measurement. Most of the healthcare system, they don't systematically measure the burnout, which needs to be included. If you are deploying AI without a baseline or without measurement, you'll not be able to measure or what are the outcomes and justify the investment as well for all these tools. The third thing is about between assistance and autonomy, like the tools which are moving from drafting notes. Again, as I said, it's related to augment the capability, not really replace it. Discussions and future directions. Typically, as we see the AI utilization of AI across those couple of case studies and utilization of those 6 domains, we saw a burnout reduction among the clinician specialties as well by 7 to 13 percentage points, which is consistently across those various studies which we did. So this consistency across the independent studies, it's what makes it credible. Although we don't know whether the gains lasted beyond 30 days or anything, but that was kind of the outcome which we did. And we had the limitations because we took only 4 years of data, or rather data from 2020 onwards, and we didn't have kind of a real exists kind of a longer timeline data. Most of them, like the couple of case studies which we did, they were also doing the outcomes or the measurements of the pre and the post for just a 1 year of survey as well. My last slide here is the conclusion. So what we discuss or derive from this thing, which like burnout management is a typically ignored subject in healthcare outcome. We always do patient-centric, patient-focused, but if the people who are providing these services, they are ignored, then it kind of becomes a real life challenge. So burnout is no longer, although it's not at the pandemic level, which was the base of our case study, but it hasn't returned to the pre-pandemic level either. The physician's recovery is real and tangible right now, but the broader workforce, as we say, the nurses, the systems, the back end, the front desk management, everything needs to be taken into consideration, not just focus on the clinicians and the physicians. So AI, as we saw some of the tools, it has the genuine evidence, specifically for ambient documentation tools. For everything else, we need to